let's move on. It's a relatively difficult topic and it very disliked topic, and it is left at the end. We will do at the end of the end. So this is that topic. So sympathetic chain, sympathetic trunk in the head and neck. So sympathetic trunk, before talking about the actual placement and branches of the sympathetic chain in the head, let's talk about a little about the autonomic nervous system in general and the sympathetic chain. Let's a little general anatomy. In any sensory system, there is a single neuron connection between the receptor and the central nervous system. There is always cell body in the dorsal root ganglion, and a single axon goes all the way peripheral axon, peripheral part of the axon, and then central part goes the central nervous system. There is no break. There is a similar situation with all the motor somatic motor fibers. There is a cell body in the central nervous system. In spinal cords, it is in the anterior horn. In brainstem, it is present in the motor nuclei. And the axon exits and run all the way to the muscles. Skeletal muscle, there is no interruption between. However, the autonomic nervous system, be it the sympathetic or the parasympathetic, it has a very unique arrangement. It has two nerves from the central nervous system to the effector organs. The cell body of the first neuron is always present inside the CNS, may it be brainstem or spinal cord, and the cell body is of the second neuron is present outside the CNS in the ganglion. We will see about the different ganglia. So the first cell body, the pre-ganglionic, presynaptic cell body is present in the CNS. The axon exits, come to outside, and it synapses with the cell body of the second neuron, that is postsynaptic, post-sympathetic neuron cell body. I will not be using the word second for now. This postsynaptic neuron cell body, it gives rise to an axon that ultimately postsynaptic, post-ganglionic axon goes and affect the effector organs. So the autonomic nervous system consists of two parts, sympathetic and parasympathetic. This is the thing that you have been reading about even before entering into the medical field, even before in the O levels, A levels, and your FSC metric. So the sympathetic nervous system is the one that helps you in the fight or flight. So remember, think about all the things that are happening. Respiratory rate is increasing, heart rate is increasing, sweating is coming, pupils are dilating, the hunger vanishes, the peristalsis goes away, you forget about going to the washroom, sphincters the close very tightly, and the peripheral and the all the blood is pumped toward the muscles to make them ready. The parasympathetic nervous system goes the opposite way. It is rest and digest. When you relax, your heart rate cools down, your respiratory rate falls down, body temperature comes down, peristalsis activity start. It gives you a feel of hunger. There is a salivation, glandular activity occur, sphincters open up. You need to void yourself. You need to relieve yourself. So that's what's happening. What's the difference between the system in anatomical terms from where they are originating? So you may take a screenshot. Behind me is all the, I'm a little hiding the functions of it. I will not be talking about the functions. You may take a screenshot for it right now. I will be talking about the anatomical aspect, the origin of it. The parasympathetic fibers, the parasympathetic fibers, the rest and digest, they are originating either from the brainstem or the sacral segments of the spinal cord. So it is originating from brainstem and sacral segments. So its origin is called brainstem, and sacral segment, its origin is called craniosacral. You should know the actual origin. In the brainstem, it is coming as the component of 4 of the 12 cranial nerves, that is 3, 7, 9, 10, oculomotor, facial, glossopharyngeal, and vagus nerves. Then these contains the fibers of the parasympathetic fiber, and consequently you can understand that they have the nuclei that are giving rise to those fibers. those nuclei are the presynaptic parasympathetic fibers. For example, in case of optic, in case of oculomotor, there is Edinger-Westphal nucleus. So in the sacral segment, it is coming from the nuclei present in the segments S3, S2, and S4. S2, S3, S4. So they are giving rise to the presynaptic fiber. They are coming outside. Parasympathetic fibers that are coming outside. Presynaptic. So that's enough about parasympathetic. Let's get to our main topic, sympathetic. You can see from here, the sympathetic fibers are coming only from the thoracic segment and the lumbar segment. They are coming from the thoracic segment and the lumbar segment. So its origin is called thoracolumbar, thoracolumbar output. This origin is strictly speaking coming from segment number T1 to segment number L2. So thoracolumbar segment. Let's dive into a little more detail. We're talking now only about this thoracolumbar segment. So we're talking about only sympathetic. So sympathetic will be present in T1 to L2. So all this talk will be applicable to T1 to L2. Here, the presynaptic sympathetic cell body, it is present in the lateral horn. It is present in the lateral horn. From the lateral horn, the axon originates. The axon exits through the anterior ramus, exits through the anterior root, ventral root, and ventral root, it comes to the spinal nerve. It is a very common sense that it has to somehow reach the sympathetic chain. It is for now in the spinal nerve, it has to reach the sympathetic chain. So the connection that helps us reach the sympathetic chain, this connection is known as white ramus communicantes. This is called white ramus communicantes. And by then white, you may get the idea that these presynaptic fibers are actually myelinated. That are actually myelinated. They come, they come into the sympathetic chain, and here they will find the post-synaptic or ganglionic cell body. Here was the pre-synaptic ganglionic cell body. Okay, here is the end of the presynaptic axon. It synapses and transmits the signal to the postsynaptic ganglion, and here the story starts from this neuron. This has to go back to the spinal nerve. It has to go back to the spinal nerve to supply the erector pili muscle and the sweat glands that it has to supply. It the it does not go back the same route. It has too much of a self-respect and ego. It has its own track. It has its own connection. That connection is called gray ramus communicantes. That connection is called gray ramus communicantes, and gray ramus tells you that it is unmyelinated. That is unmyelinated. So by this information, it goes back to the effector, and the effector may be the skeletal muscle arteries, they may be erector pili muscles, they may be sweat glands, and so on. So this is about the major simplistic pathway, the simplistic route. Now, one thing I want to tell you here, this point of information can give you an point of MCQs also. You will have an MCQ about where the presynaptic ganglion are present, T1 to L2, where are they present in lateral horn, what are the type of fiber, myelinated, how do they go to the sympathetic chain through white ramus communicantes, then starts with gray ramus. Gray ramus is unmyelinated, with the which one is lateral of the two. White ramus is lateral, gray ramus is medial, and so on. These questions can be asked. So white ramus will only be made due to pre-ganglionic. Pre-ganglionic will only come where there is output. So white ramus communicantes will present only in T1 to L2 segments. However, the gray ramus will be present in all C1 to coccygeal segments, all 33. Okay, so this is about that. So this is a little summary of other things. This is a picture from Gray's Anatomy. So these postsynaptic neuron, these postsynaptic cell bodies, they make up this ganglion, this chain. This chain, that long chain that forms on either side of the vertebra, is called sympathetic trunk, sympathetic chain. It consists of about 3 cervical ganglions. These are called superior, middle, inferior. We will be discussing in detail. Then there will be 12 thoracic ganglion, then there will be 5 lumbar, 5 sacral, and ultimately 1 coccygeal from each side. They will join in the midline to form ganglion impar. The inferior thoracic ganglion fuses with the inferior cervical ganglion fuses with the first thoracic ganglion to join to form stellate ganglion. And this is it. We will discuss it again. And there is a little variation between the numbers that is not universal, and it is due to the fusion or separation of the ganglia. And this actually is the case in the neck region, because the cervical region is actually the fusion of what was supposed to be 1, 2, 3, 4 ganglions that have fused to form the first superior cervical, then the next two, and the next two. As we talked about, the white remix communicantors will be present only where there is a sympathetic output. They will be present only in the L1, T1 to L2. Gray remus, however, will be present throughout. Synaptic pre-ganglionic ganglion, so we have discussed that. So once we discussed the very simplistic arrangement, how the pre-ganglionic reaches the sympathetic chain. It was cell body present in lateral horn and exits through ventral root, spinal nerve, white ramus communicantors, and sympathetic chain. Now it has reached the sympathetic chain. One fate we discussed that it synapse exits back with the gray ramus and so on. But there are about 3 fates. We can group them together. There can be more if we go into the further detail. One thing is that when they have reached the sympathetic chain, they immediately synapse at the same level, and then after the synapse, the post-ganglionic exits. Second situation, when the egg enters, they may move up and down the sympathetic chain, and they will exit from there. The third option is they may not synapse at all. Let's go into the detail. This was the first one, the one that we saw in the previous example. There was presynaptic sympathetic ganglion in the lateral horn, exits through the anterior root, comes to the spinal nerve, reaches the sympathetic chain through the white ramus, and here it synapses with the cell body shown by the circle here at my pointer, and its axon, unmyelinated axon, go through the gray ramus communicantors into the spinal nerve, and through it, it will be disseminated in different parts. What about these segments? There is no inflow to this part of the sympathetic chain, the cervical ports. There is no inflow to the lower lumbar and sacral part of the sympathetic chain. How are they getting the presympathetic fibers? So for these, this makes the way. The entering pre-ganglionic fiber, it may go up the sympathetic, it does not synapse immediately, and it starts climbing up. It goes up the sympathetic chain. Or in the lower regions, in lumbar regions, it may enter through the sympathetic chain through the same pathway, but without synapsing, it may move down to the other region. In the lower regions or in the upper regions, after changing the level, it may synapse, and after it may synapse and go to the gray ramus communicantors into the spinal nerve and supply that area. The same is true for the upper region, same is true for the lower regions. Here you can see the visual representation of the things about the two rami. From L1 to T1 to L2, where there is an outflow, there are both ramus. There is white ramus communicantors and there is gray ramus communicantors. For input, white ramus; for output, gray ramus. For the others, in the cervical region and in the lumbar region, there is only gray ramus communicantors, because it does have a post-ganglionic fiber getting out into the spinal nerve, but it does not have a pre-ganglionic fiber coming in. The pre-ganglionic fibers are coming by moving up and down the sympathetic chain. So this is about the pathways. This is the level changing. A little bit for going into the more complex. It may synapse early and then change the level. Also, this may also occur, but leave it for that. Then there is the ones that exit without synapsing. There are four nerves made from this. You must have read it in the abdomen pelvic region. These are greater splanchnic, lesser splanchnic, least splanchnic. And the fourth one is lumbar splanchnic. The pre-ganglionic reaches the sympathetic chain through the same pathway, but there without synapsing, it exits and come out of the sympathetic chain, and it is now pre-ganglionic and myelinated, and it will remain pre-ganglionic all the way when it reaches the celiac or renal, simply speaking pre-aortic nodes, celiac ganglion, and here it will synapse and give rise to the in celiac and mesenteric, inferior mesenteric, it will give rise to the postsynaptic fibers that will move along the arteries of the gut. So these are splanchnic. You must have remembered the branch or root values. T5 to T9 they form the greater splanchnic, T10, 11 form the lesser, 12 form the least, and L1 and L2. This is usually forgotten because we are so busy with greater, lesser, least splanchnic that it goes to the these are the pre-ganglionic splanchnic fibers, and they can be seen right here. They independent nerves and they move, they penetrate the crust of the diaphragm and they go down. Postsynaptic sympathetic fibers, all the rest of the viscera, the fibers that are going to the esophagus, stomach, the esophagus, heart, and lungs, trachea. These are also known as splanchnic nerves, but those are not pre-ganglionic splanchnic nerves that right like we discussed before. These are post-ganglionic splanchnic nerves. So the point of telling you this was, if you read about the cardiac splanchnic nerves, don't say that immediately it is pre-ganglionic just on the basis of greater splanchnic and lesser splanchnic nerves. Talking about the sensory fibers from the viscera. So the sensory fibers from the viscera, the information from the gut, the information from the heart, it travels back through the along the spinal nerves, along the sympathetic nerves that were supplying them, and when it comes back with the sympathetic nerves, it follows the same route. It with the sympathetic nerves, it reaches the sympathetic chain, and from the sympathetic chain, it goes to the spinal nerve via white ramus communicatus. ये बात भी याद रखनी है. You have to remember this, that the sensory nerve they re-enter the spinal cord via white ramus communicatus, and this will explain so many things to you, like heart. Heart is being supplied by a sympathetic chain from the superior cervical ganglion also. So the superior cervical ganglion has connection to the C2, C3, C4, C1, but you feel the referred pain only starting from T1 because the white ramus communicated it started at T1. So that is why the visceral pain, referred pain, you may not in the normal, in the every situations, you won't read about them beyond T1 to L2. Even the abdominal region, appendix, cecum, descending colon, you will read about from T1 to L2. So, about discussing all of this, we come to the conclusion that what the structures are making sympathetic chain. It was consisting of presynaptic fibers, it was consisting of postsynaptic sympathetic fibers, and of course, the cell body of the postsynaptic neuron. And in addition to that, visceral afferent fibers traveling along the sympathetic fibers on the way to the dorsal root ganglion, they do cross the sympathetic chain. In addition to that, there will be supporting cells. We can discuss more in the histology. There is will be for the myelination and for the covering of my Schwann cells for the myelination and stellate cells for covering of the cell bodies. Let's get to the actual topic. It was a very big preamble. That's the beauty of the recorded lectures. You may have skipped to move to the cervical sympathetic chain. Um, it is in the thorax. It is from the base of the skull to the thoracic inlet, first rib, and it is medial to the highest intercostal vein. And that's something about the relations. I have not shown a picture here. Let's move to the ganglion actual. There are three ganglions. The largest one is the superior cervical ganglion, then there is middle and inferior. The superior cervical ganglion is present very near to the vertebral artery, medial to the vertebral artery, and it is lying in front of the prevertebral fascia. The prevertebral fascia, um, the one that was in front of the longus colli and the scalenus anterior. Let me change a lot of slides immediately. Yes, here you saw that sympathetic chain was lying in front of the prevertebral fascia. So it's lying outside the prevertebral space. It is lying in front of the prevertebral fascia. And it is medial to the vagus nerve. Here is the vagus nerve, and it ends in the superior cervical ganglions. Okay, this is a sympathetic chain. Let's talk about ganglions one by one. Ganglion 1, superior cervical ganglion, it is present in front of the cervical transverse processes C2 and C3. Here it is present. Middle cervical ganglion, it is present at the level of C6 transverse process. It is shown here. Behind it, palpable, it's the Casagnac tubercle, carotid tubercle, and it is related to the inferior thyroid artery right here. And the third one is the inferior cervical ganglion. It is present in front of the first rib, and it is behind the initial originating part of the vertebral artery. So there is one thing that is ulnar subclavia. The sympathetic chain connects the superior with middle, middle with inferior, and so on with all of them. However, the connection between the superior, middle, and the inferior, it is not simple chain. The chain is split into two. Some part of the fibers they loop around the subclavian artery and moves to the inferior ganglion, the stellate ganglion. Here it is a little more visible. So it moves as like this in front of the subclavian artery into the inferior ganglion, cervical ganglion. This is known as ansa subclavia. This is an anatomical picture. You can take a screenshot here right now. Stellate ganglion. It is to emphasize that a single person may have stellate ganglion on one side and separate inferior cervical and T1 ganglion on the opposite side. Let's talk about the branches, C1 branches, C2 and so superior and middle and inferior. First, Grere muscommunicatus. It arises from the lateral aspect and it applying from the lateral aspect and supplies C1, C2, C3, C4, and these will supply the post-ganglionic sympathetic fibers to area of supply of these dermatomes. Second, cranial nerve branches. Some nerves they join the vagus nerve, glossopharyngeal nerve, and hypoglossal nerve. These joining nerves they become a part of pharyngeal plexus. So, when talking about the pharyngeal plexus and the head and neck region, you may read that vagus nerve supplies the sympathetic fibers to the pharyngeal plexus. So, it is not actually that vagus nerve is sympathetic. It's simply that these fibers are getting a piggyback ride. They are getting a ride to the pharyngeal plexus. There may be direct branches going to the pharyngeal plexus also. And the direct branches may split the carotid body. The carotid body was shown, I think it was shown, I don't remember it now. Okay, yes, the carotid body and sinus. The carotid body and sinus, the carotid body was the chemoreceptor of the arterial blood, and carotid sinus was the baroreceptor of the arterial blood. We will discuss them tomorrow, inshallah. And then there are arterial branches, the branches that are going along with the internal carotid and external carotid artery, the plexus, sympathetic plexus that is formed around these arteries. The branches are coming from superior cervical ganglion. And then each of the three cervical ganglion give a cardiac branch, and the one from the superior cervical ganglion is called superior cardiac branch. Then there is middle cervical ganglion. Middle cervical ganglion, it's present behind the at the level of C6. It supplies C5 and C6. The greater communicants gives rise to the arterial branches to the inferior thyroid artery. You might have remembered that it was very closely related to the inferior thyroid artery. So it gives a nerve plexus to the inferior thyroid artery that leaches the thyroid gland. And the last one, the cardiac branch, the middle cardiac branch, that is from the largest one. And then there are also branches going to the trachea and esophagus. Just remember, the cardiac, trachea, and esophageal branches may be labeled as parenchymic, but they are sympathetic, but there are postsynaptic. Inferior cervical ganglion is the largest one, is the not the largest one, it's the lowest one, more inferiorly. It is fused with the first thoracic to form stellate ganglion, and it supplies the branches of C7 to C8, and it gives arterial branches to the subclavian artery, and from it to its branches that include the vertebral artery and so on. And these will go to the also give rise to the cardiac plexus, deep branches of the cardiac plexus. You may get it by now that the middle and inferior cervical ganglion, they are supplying C5, C6, C7, C8, and if joined with the first thoracic T1, they are supplying the brachial plexus. Cardiac nerves are three in number. They go to the superficial and deep cardiac plexus, and this cardiac plexus is present right here under the arch of aorta, in front and to the right of the ligamentum arteriosum, in front of the pulmonary arteries. So this is the cardiac plexus, and these are all branches coming from the three cervical, up superior, middle, inferior, and the branches to the thoracic plexus is coming from the thoracic segments. Also, we will discuss that in thorax. Horner syndrome. What if the sympathetic chain stop giving the outflowing signals? It may be interruption at the brainstem level. There will be higher there will be brainstem lesion, cervical segment lesion. They may affect it, and in the later syndromes, you talk about Horner syndrome. Later medullary syndrome is one of the examples. Thyroid carcinoma, cause tumor of the apex of the lung, and penetrating injury. They may directly affect the sympathetic chain that is running on each side of the vertebral column. And even the cervical vertebra, cervical rib, that may cause a traction on the that may cause a traction on the rib to make it. What are the symptoms? Symptoms, it's the upper eyelid drops down because sympathetic supply to the levator palpebrae superioris is lost, so there is ptosis. The sympathetic to the sweat glands is lost, there is no sweating, there is anhidrosis. There is loss of supply to the dilator of the pupillary muscles, so there will be constriction of the pupil, that is known as meiosis. And due to the meiosis and dropping of the eyelid, the eye seemingly feels like the eyeball has sunken deep into the eye socket, that is called enophthalmosis. There is another possible explanation for that. There is a muscle called orbitalis in the inferior orbital fissure that is supplied by sympathetic fiber. If that is not functioning, the eyeball goes a little back also physically. So these are the features: ptosis, meiosis, and hydrosis in ophthalmosis. Stellate ganglion block may be done for some therapeutic and diagnostic regions, especially if there is an oversympathetic drive or some visceral sensations coming through this pathway through the sympathetic chain are causing more pain. So in of these cases, there is a block of the sympathetic chain. To get to the sympathetic chain, remember the chasic neck triangle. That chain was running in front of it. So needle is inserted at the level of carotid tubercle and it directed behind and inferiorly and medially until it reaches the sympathetic chain. And then there is sympathetic arterial insufficiency of the upper limb. Some people have overdrive of the sympathetic system, and they have a very high flow of the sympathetic impulses to the upper limb that troubles them in the way that their arteries remain in the state of constriction, and whenever they have to do some physical work, their blood is not compensated, and they have pain and they have issues. So what is happening is that actually the fibers that are going into the upper limb, the nerve fibers of the upper limb was sympathetic chain. Sorry, the nerve fibers of the upper limb was brachial plexus. Just remember, in the previous slide, you studied that the upper limb, the sympathetic, the brachial plexus was being supplied by middle cervical ganglion and stellate ganglion. So even if the fibers supplying the upper limb are exiting through T2 to T8, they have to climb up the chain. They have to reach the T1 and stellate ganglion at the inferior end. If they are separate, the T1, first thoracic, inferior cervical, and the middle cervical ganglion, and from there they have to go to the C5 to T1. So what to do is not to if we just damage the sympathetic chain, we are at a verge of we will create Horner syndrome. So we can't simply break the sympathetic chain. So what we do that we break the connection between T1 and T2. So even the outflow tract is reaching the sympathetic chain right here. It does not reach the, it climbs up and is interrupted right here, maybe by cutting, maybe by clipping, and it does not go up. And when it does not go up, it cannot go into the brachial plexus by greater communicantis of C5 to T1. So the sympathetic spike of the upper limb is interrupted. At the same time, most of the outflow for the head and neck is coming from thoracic outflow. So T1 is intact, and the fibers will go up and the Horner syndrome will be avoided. So this is about the clipping. So thank you for listening. Today's lecture, most of the pictures are from Netter's Anatomy and Gray's Atlas of Anatomy. One of them or one or few of them was from the Snell's Clinical Anatomy by regions. I did not discuss almost anything on the 3D model. So let's keep it for tomorrow, inshallah. I was using otherwise 3D4 complete anatomy by 3D4 medical by elsewhere. So thank you so much for listening. Thank you so much for being online with us. If you have any queries, questions, and suggestions, please drop down in the comments below. Inshallah, I will try my level best to answer these. See you next time, inshallah. Allah Hafiz.